Okay, now the recording is started. So let me get back to my slides. Uh, okay, so this was the diagram I gave you yesterday, and this diagram shows how streptokinase here and alteplase work. Okay, and if you just for a reminder, you should understand and remember by now, key streptokinase and alteplase, they are both what? They are fibrinolytic drugs. What do you mean by fibrinolytic? Those drugs which dissolve the already formed clots. Okay, fibrin. That means your blood is already clotted, and now you want to dissolve that. Where do you need this? You need this when you need to dissolve already formed clots in conditions like myocardial infarction, pulmonary embolism, ischemic stroke, okay, and arterial occlusion anywhere. Wherever there is occluded artery because of this thromboembolism, and if we do it in time, I am reminding you again, if we do it in time, it will reverse all the symptoms of that condition. Okay, but if you don't give it in time, that means if you give this after 4 hours, when reversible necrotic involvement is already begun in the tissues, then you can do nothing for that. Okay, that means that it is optimal to use these drugs after the insult within 4 hours, and it is still given for the first day, but after the first day it is you don't have any benefit. Scientists and the doctors, they say even after 4 hours the benefit decreases dramatically, so you should aim for before 4 hours. But the protocol in many hospitals, what they do is they don't limit it just for 4 hours, they extend it some for 12 hours, some for 24 hours. Okay, and but the outcome is debatable for that. So what interesting thing I was talking about is streptokinase alone is not doing anything. It's not an enzyme. It is an enzyme, but has no enzymatic activity until and unless it combines with its own substrate, that is plasminogen. Okay, it is going to change plasminogen into plasmin. And for your reminder, what is plasmin? Plasmin is, anybody? Can you answer me? What is plasmin?
Fibrinolytic
Nobody is
acid.
answering. Sorry? Can you tell me again?
Fibrinolytic acid.
Is plasmin fibrinolytic? Yeah, it is a natural. First, what you should say is what is this factor 2? What is factor 2 of this blood coagulation factor 2? Huh, guys? You don't remember anything from physiology and other previous pharmacology classes?
Prothrombin.
Yes, factor 2 is prothrombin. And what is the use of prothrombin? Guys?
To activate thrombin.
Yes. Prothrombin will activate fibrinogen into fibrin, and fibrin will activate what? It will activate plasminogen into plasmin. What is plasmin? It is a natural lytic agent, as she correctly said, of fibrin. Why do we need that? We need fibrin to clot the blood, to stop hemorrhage, isn't it? But we don't need fibrin forever. After naturally healing of the wound, you don't anymore need fibrin or the clot. For that purpose, plasmin is there, and it will slowly, if you remember, slowly digest fibrin from inside. Plasmin will get inside the fibrin clot, and then it will start lysing it from within inside. Okay, so that is plasmin. And what our streptokinase does is it will increase the rate of plasmin fibrin activity, or not plasmin fibrin activity, plasminogen converting into plasmin very rapidly. Okay, streptokinase and plasminogen combination. So that is how the natural process of slowly lysing of this clot will become immediately very fast, okay, super fast, okay. So that thing can open up the clogged blood vessels. And similarly, alteplase, what it does is, again, alteplase also very interestingly doesn't work alone. It will bind and go inside fibrin again, okay. So again, this is fibrin, uh, alteplase wants to dissolve, but it gets inside the fibrin first, and then as I showed you yesterday, that plasmin also is getting inside the fibrin. No, just now also I told you previously that plasmin is absorbed inside the fibrin clot, and it will degrade the fibrin from inside. Now alteplase also goes to the same place inside the clot where plasmin is there already. Okay. Now and this combination of alteplase inside fibrin activates the alteplase effectively, and again this will potentiate the change of plasminogen into plasmin. Okay. And what is the benefit of this alteplase is that it is activating the plasmin inside the fibrin. That means it is more uh, effective in pathological or this clotted already formed clot, and it doesn't activate the plasmin that is running with the blood. That means the free plasminogen which is roaming with RBCs and WBCs, they are not affected that much. Okay. But the plasminogen which is been absorbed inside the clot is affected. That means it has some selectivity in the action, unlike streptokinase. So that makes alteplase slightly better and slightly narrow, that means slightly selective to pathological thrombus than uh, other thrombus. Okay. So now if you want to write this thing in your examination, then you can write it in this way. Okay. Mechanism of action, streptokinase combines, you can write it down, right guys, copy it down. I'm going to upload some of these slides in the classroom after I finish this class. But nevertheless, you make a habit to jot down some things that I claim as important or something like that. Okay. So streptokinase combines non-covalently with plasminogen. That means it is not a permanent bondage. After some time, it will get detached. But I mentioned yesterday that this is not the case with alteplase. Alteplase combines permanently. Okay. But streptokinase, it can after some time detach away, and this streptokinase and plasminogen combination undergoes conformational change. The structure is changed. Okay. Then the changed structural structure of this streptokinase and plasminogen will convert plasminogen into plasmin, and then fibrin is degraded to FDP. This is fibrin degradation product. Okay guys, FDP is fibrin degradation product. I told you yesterday as well. And alteplase gets activated when it is in contact with fibrin, that I told you just now in the figure. This combination converts plasminogen into plasmin, and fibrin is degraded to FTP. So a very similar type of thing, but but working by combination with different substrates. Okay, you remember this, and it is okay. You can, if you write these things in examination, you will get enough marks. Or if you know these things, then it will be enough. Okay. So I told you yesterday that protein is synthesized. This is synthesized from streptococci, and we have three forms. Like first one is urokinase. Urokinase is derived from human kidney, guys. Okay, and it doesn't need to be combined with plasminogen to active plasmin. Okay, so it can work by itself. It is just like a combination of streptokinase and plasminogen. Okay, so that is what urokinase is. Anistreptase, on the other hand, is not is a complex of streptokinase and plasminogen. Okay, this is already made thing which is supposed to give more rapid action as compared to streptokinase. And similarly, Altiplase, you can see that it is. I told you that TPA is an our own conversion. It converts. What is the function of RTPA in our body, guys? Anybody? Can you tell me? RTPA is the thing that binds to fibrin, okay, and converts plasminogen into plasmin. That is, it is again the enzyme that we have naturally in our body, and that thing can be administered from outside. I'm repeating this thing from yesterday just to make you understand. And what is the basic difference between streptokinase and Altiplase is that it is non-antigenic, guys. It is not an antigenic. That is why it is more commonly used in Western countries, and our countries in this part of the world doesn't use it more commonly because it is very expensive. Okay, so what are the uses? This is also revision from yesterday. The uses are acute myocardial infarction. Okay, again remember that you should give it in time. The time factor is very important. Deep vein thrombosis, pulmonary embolism, peripheral arterial occlusions, and ischemic strokes in your brain. And I gave you some contraindications like surgery within 10 days, metrorrhagia or heavily menstruational bleeding, serious gastrointestinal bleeding from ulcer and non-ulcer and Crohn's disease and other inflammatory bowel diseases. Active bleeding from hemorrhagic disorders, any type of hemophilia or any other hemorrhagic disorder where you can see bleeding, okay, and then and others. So another thing we didn't discuss yesterday is antifibrinolytics. Okay, what is antifibrinolytics? Antifibrinolytics are the drugs that is just opposite to that of this streptokinase and Altiplase. Okay, streptokinase and Altiplase, what do? They will dissolve the clot. What these antifibrinolytics will do? It will prevent dissolving the clots. Okay, so where and how we use it? What is the mechanism of action? So there are basically two drugs I'm going to talk about. The first one is this one. First one is this one, aminocaproic acid or epsilon aminocaproic acid or EACA. Okay, different books give different names. Okay, EACA, I think KD Tripathi gives you EACA, Goodman and Gilman gives you aminocaproic acid, or some books they will write the full name epsilon aminocaproic acid, but most of the times you can see aminocaproic acid is used. Okay, so aminocaproic acid is a potent inhibitor I write, is a potent inhibitor of it is an potent inhibitor of fibrinolysis. So why it is used? It can reverse the states associated with excessive fibrinolysis. What do you mean? If you somehow give excessive fibrinolysis therapy, for example, streptokinase you have given, and all of a sudden because of excessive dose, bleeding starts. Okay, so what do? You give antifibrinolytics. This is just like antidotes. Okay, and it can be used not only for antidotal purposes for streptokinase, but it can be used for other hemorrhagic conditions. For example, it can be used to prevent reoccurrence of subarachnoid and GI hemorrhage. Okay, so once hemorrhage is there, if you can take it, and it will effectively prevent re-hemorrhaging. Okay, certain traumatic and surgical bleedings like prostatectomy, and in hemophiliacs, after tooth extraction, if it is bleeding too much, after tonsillectomy, if it is bleeding too much, any capillary type of bleeding, it cannot stop oozing arterial bleeding. Why? Because there is no time for the clot to form over there, and basically it's not for fresh wounds. Okay, fresh wounds, there will be no clots for it to prevent dissolving. Okay, so if there is slightly after one time hemorrhage is was there, and then you stop somehow, and if you want to maintain that hemostasis, then you use this EACA, aminocaproic acid. Okay, how does it work? It is a lysine analog, guys. Lysine analog. What is lysine? Lysine is an amino acid. Okay, and this lysine analog uh, competes, because it is lysine. It competes with lysine binding sites of plasmin to and because of that, it will block the interaction of plasmin with fibrin. Okay, it will block the lysine binding site for plasmin, which is needed in order to have interaction with the fibrin. Okay, once that lysine binding site is occupied by this fibrin, then only it is able to block this dissolve this clot mm, uh, without presence. If there is no presence of EACA, plasmin will bind to fibrin and dissolve it, and fibrin will bind to plasmin in which site? Lysine binding sites. Okay, and that is blocked by this aminocaproic acid, which will effectively prevent blocking of interaction of plasmin with fibrin. So this is the mechanism of action. So where do we use it? I told you briefly before also. Overdose of streptokinase alteplase to prevent reoccurrence of subarachnoid hemorrhage, to shorten traumatic surgical bleedings like prostatectomy, hemophilia, tonsillectomy, tooth extraction, any even in gynecological hemorrhages like postpartum hemorrhage and others, in hypermetrorrhagia, okay, excessive bleeding in menstrual cycles. In those cases also you can use in postpartum hemorrhages like abruptio placentae, when the placenta is torn up from before birth, PPS, postpartum hemorrhages, and in menorrhagia you can use this drug, and it's commonly used. Okay, and more commonly used drug is another one that is called tranexamic acid. Okay, tranexamic acid is more commonly used in gynecology and surgery. So mechanisms and indications are same, though the structure and even the thing that is aminocaproic acid chemical properties and chemical structure is completely different, but mechanism of action is the same. It will bind to the lysine binding site in the plasmin, and it will block the interaction between plasmin and fibrin. Okay, that means fibrin will not be able to dissolve in presence of tranexamic acid because it is blocking the plasmin. Okay, and it is more commonly I can say that in Nepal and India, it is more commonly used than aminocaproic acid. Okay, how do you use it? You use it 1 gram QID for heavy menstrual bleeding. Okay, and should be continued for 4 days. And I told you yesterday, before in the previous slide as well, that we can use it in all surgical processes like tonsillectomy, prostatic surgery, tooth extraction, hemophilia, anything. Okay, and you can, even in recurrent epistaxis. Okay, if you use tranexamic acid in epistaxis, it can hold the clots in place, effectively preventing reoccurrence of hemorrhages, trauma, ocular trauma, any trauma, bleeding, peptic ulcer, everywhere. Okay, and not to forget overdose of fibrinolytics like streptokinase and antiplatelets is effectively blocked by tranexamic acid, guys. So this is what I wanted to give you for today for this class. But I wanted to go back to anticoagulants. Okay, guys. So today's remaining of today's class, we will be discussing something about heparin and warfarin. Okay, guys. So what I was going to discuss is, I want to ask some of you some questions, and we can discuss it in a cumulative way. Okay. So Naveen Bhandari, are you there? Naveen Bhandari. Naveen Bhandari, don't worry if you are not able to answer my questions. I will be answering you if you are not able. Okay, Naveen Bhandari, are you there? He has gone somewhere. Computer is on, but the person is not there. Naveen Bhandari, I'm going to record you. Dhirendra Chaudhary, are you there? Guys, am I online?
Yes, sir.
Yes, sir.
Oh,
Yes, sir. Yes, sir.
okay. So many yeses, but so many silences are there also. Janvi Bansal, are you there? No. Shreya Hirachan, are you there?
Yes, sir.
Ah, at last somebody. Shreya Hirachan, are you Shreya Hirachan? I can't find you right now. Okay. Uh, don't worry if you can't understand, can't answer it. I will answer it. But can you tell me what is the mechanism of action of heparin? Huh?
It inactivates
Heparin.
thrombin and
Sorry?
factor.
Sorry, can you tell me again?
It inactivates thrombin and factor 10.
Thrombin. It inactivates thrombin by inactivating antithrombin T, I think, and antithrombin 3, I think. Nah? Okay. Does anybody know what is antithrombin 3, guys? No. Okay, now tell me, what is the difference between iridine and heparin? Nobody? Salina Subedi? Salina Subedi is not there? I think nobody is there. Everybody is just turning on their laptops and running around their houses, na? Okay, what to do then? You don't want to participate? Even I say I will be helping you. You are not eager to participate. Okay. So then what to do? You don't want to listen to what I have to say with regard to heparin and warfarin and other things? There are very important questions. Okay. Since you are not participating, I'll give you the important key points. Next time, next class, I'm going to ask you all. Okay. And those who don't respond to me when I'm asking will be considered as absent. Okay. Next time. Today, I didn't warn you last time. So next time, 2 classes I have. We are going to discuss practicals as well as theory of this topic. Okay. And I'm conducting an active session, not like lecture. Okay. You are going to talk to me, I am going to talk to you, and if you don't talk to me while I call your names, I will consider you as absent. Okay. So what are the points that needs to be read by you and understood by you? Tomorrow I don't have class. Day after tomorrow I think I have class on Friday. That time I'll come and have discussions with you, and I want you to know these things. Okay, the things apart from the things I taught you, Durga madam taught you about anticoagulants, and I'm going to include my questions from anticoagulants, fibrinolytics, and antiplatelets. All okay. So, what are the things and questions you need to consider with regard to anticoagulants? Is in heparin, mechanism of action of heparin. Okay, and to understand mechanism of action of heparin, you need to understand two things. One, what is thrombin, another, what is antithrombin 3. Okay, so you need to understand that. What is thrombin, what is antithrombin 3, what are the functions, physiological functions of these two things I just told you, and what heparin does. Okay, one. That means after understanding these things, you will understand what is mechanism of actions of heparin. What are the indications of heparin? Okay. If heparin, you write it down. If heparin works in vivo or in vitro. If it works, why? If it doesn't, why? Okay. In vivo, you know that in live body. In vitro, that means you have separated the blood from your body and then you use heparin. Will it work or not? If it works, how it works? If it doesn't work, how it doesn't work? What is the antidote of heparin? Okay, what is the antidote of heparin? What are the adverse effects of heparin? What are the most famous adverse effects and most dangerous adverse effects of heparin? Hint, thrombocytopenia, HIT. Okay, that is a hint. Next time I'm going to ask you. What are other aspects of friends of heparin? Okay, that means congeners like hirudin, agratoban, melagatran. What are these? What are the differences between hirudin and heparin? Okay, these are all heparin and heparin-like drugs. Okay, another thing is you need to know what is from pathology. What is APTT? Okay, what is APTT? PT and BT. Okay, APTT, I'll ask you. APTT, PT, and BT. This is not pharmacology at all, but you need this in pharmacology. Okay, and what is the monitoring procedure for heparin? This is a very important question. What is monitoring? How do you monitor heparin in your body? Okay, so that is one of these, either APTT, PT, or BT. You should understand that. And from warfarin, you should understand by now what is warfarin. Warfarin is oral anticoagulant. Heparin cannot be taken orally. It will degrade in your stomach. Heparin cannot be used IM. It should be only used SC, subcutaneous or IV. I'll ask you tomorrow why. Okay. So another things you need to prepare for tomorrow is, day after tomorrow is, what is warfarin? Okay. The same question here. What is the mechanism of warfarin? Okay. What relationship it has with vitamin K? Okay. Why warfarin works after 1 week, or it has a long, late onset of duration of action? Okay. And why heparin acts immediately? Is warfarin effective in vitro or not? If it is effective in vitro, why or how? If it is not, why and how? Okay. What are the antidotes of warfarin? If there is warfarin excess in your body, poisoning, what do you use? Okay. Similarly, in heparin, what do you use? I just gave you those things. what are the uses of warfarin, obviously. So these are the questions we'll be discussing in the next class. What else I have to tell you is, just let me see. Okay. So please, are you there with me, guys? Am I?
Yes, sir. Yes, sir.
Okay, okay. Tomorrow, I'm repeating this. Okay. Tomorrow we'll have not tomorrow. Day after tomorrow we have class. I'll be asking you questions. I'm expecting that you will be discussing with me tomorrow in this class. And again, I'm repeating this. Anyone who is not responding to me when I ask questions will be marked absent, right, guys? But if you state your answers incorrectly, I am there to help you. You will be present and you will understand the question. But if you keep quiet, you will not understand and you will be absent from the class. Understood?
Yes, sir.
Okay.
Yes,
So any questions for today? Apart from the question I asked and asked you to prepare, if you have some other questions that you didn't understand, you can ask me right now. No questions?
sir.
Yes. Who is it speaking?
So yesterday you gave one question to us.
Yeah, what was that?
Why heparin is combined with altiplate?
Yes. I was expecting that somebody will ask me, because yesterday I gave you that question and I deliberately didn't start that conversation today because I wanted to ask you tomorrow. Okay. And that is the reason that I didn't explain it to you right now. I will give you a hint. Okay. Alteplase and heparin, they are not supposed to be combined. Okay. They have toxic effect if you combine, but still they are combined in some cases. You tell me what are the diseases you can combine heparin and alteplase and they are considered good, and what are the chances, what are the risks that is associated with this, and why do we keep doing it despite of that risk. Okay, so I am not going to give you this answer, all the detailed answer today, but I'm going to discuss this thing with you in the next class. Is it okay? Yes, sir.
Yes, sir.
Okay.
Sir, I have doubt.
Sorry. Tell me the doubt.
Yes, sir, I have 4 questions. Like I posted it like on the chat.
Who's this?
Maybe yes, sir.
Oh, Nivya. Yeah, you
Yes,
posted
sir.
the question from, not from this this chapter, but you posted the question from
Yeah.
anemia.
Yeah, and yeah.
Yeah.
Yes, sir.
So those questions from anemia, we can discuss it later on, or you can direct the
So, like,
question.
from the
What's the
previous,
teacher
from the
taught?
previous.
Sorry.
So from the previous, like.
Yes. Who
like,
taught you that chapter?
So I think Durga ma'am and.
Sudesh sir. Okay.
Yes, and
You
yes,
can
and him.
first try to send them some personal messages with those questions, and then you can discuss it. We have 2 classes more. Okay, you try to ask them once, because
Okay.
they will be giving you good answers because they are the ones who taught you. After that,
Oh, okay. Okay.
after that, in the next period we'll be discussing these things, and one class we have left. In that class, I'll try to answer the questions apart from this chapter. Okay, that chapter is
Oh,
different. If I keep on
okay.
talking about anemia now, then this should confuse most of you. So we'll talk about that in the third class. The class
Okay.
after the second class. Okay.
Okay. Thank you, sir.
Bye bye. This much for
Bye.
today. You are free to go.
Thank you, sir.
Bye bye.
Thank you.
Thank you, sir.